That is why we know that the segmentation is the base for the perfect matching, and you are on the right way. And I love the lecture of Stefan showing that. I'm really addicted. So that at that time, the manual matched virtual patient was uploaded in a movement, and the uploading in the movement or introducing the movement in RayFace would be wonderful and possible. That is a digital walks-up. Then we go for the planning of the implants and for the planning of the guide. We work with 2 guides. This is not something that has to be treated today, but this is how we go. And then we go for the surgery. We respect the aesthetic proportions. We manufacture all the prosthetic parts in advance. We go to the surgery, and what do? We use scan bodies which are jumping over the distances between the implants. They have different forms, different lengths, different heights, and what is important is they have one-to-one the same library files. This is the second origin. It's not only the position, which will be done by photogrammetry. So this study shows that this method is giving you the highest precision possible. Yeah? So using that kind of method or anything what is used, important are the principles. Maybe tomorrow afternoon will be another method which is similar, but this is important. And the scanner which is prone to full arch rehabilitation. So we do a scan over this situation, and we match it with the library file, and we have a perfect provisional adapted to the face, right? Which we did in advance with a nice walks up depending on the face. Now, if the provisional is nice and then the final is even nicer, using all kind of parts which is aesthetically pleasing and promoting the soft tissue quality, and we have the perfect position and structures which will make this work to last forever. So this is the scan over, and then we have a matching again with a walks up from before, and we have an titanium base as we saw in other works also. So now, of course, my workflow changed with the RayFace, right? I was more than happy. I didn't even think about anything else, because it was exactly the missing link in my workflow to take this patient and take advantage of the automatic alignment of the iOS and the cone beam CT, and being able to export it either in the movement or also in the exocad, as you heard before, right? So then the provisional was made in advance based on the smile design of the RayFace, and you can see that we do with the help of the face and matching the avatar with all the structures we do to the implant. We go for the implant planning, as you can see. It's matching the walks up with the implant planning. So that is why we have planned the implants, we respect the parameters, we go through the surgery, we scan it accordingly with a high accuracy intra-operatively, so that is the scan, and we make the provision. So this is the new routine. It was my dream not to go out in full arch rehabilitation out of the digital chain. So this is the way to go. This is the provisional, and all this study, as the retrospective study shows, and many, many more cases which we don't have time to discuss about, shows really high success rate, but not only of the success rate, but also aesthetic success and functional success, exactly what you addressed in your lecture before. Now, when we match, after 1 year, the scans of the situations with the cone beam CT, we see that we have stable volume with all these aesthetic parameters, which need actually an extra lecture, but those are aesthetic parameters to respect, independent of the facial aesthetic, which we solved now with RayFace. Now, of course, is needed more studies. And with Stefan also, we need more studies, more input, more clinician input, and also studies about the accuracy of matching. Because AI has some question marks, the way we discussed, right? I dreamed 2 years ago about the automatization of the necessity of automatization of the matching and of the planning of the implant. And now we have it. We have Rayface with automatization of the matching, and we have implant planning software, which is planning the implant on a button. What is also reality, what we do in the digital dentistry, is communicating through AR, which is also an AI-based technology. We communicate with our technician, we communicate with the patient, and we also doing planning 3D, which is a 3D planning, right? You see the implant's position all around. Of course, there are limitations of AI, of the ethical limitation, inaccuracy of the data. I think that is a technology which needs a lot of regulation, but nevertheless, computers are unbiased, are not tired, are not bored, they are fast, so they are definitely better than us. And I agree with Roland, robotic is here already, is an robotic-assisted navigating or dynamic navigation. Actually, dynamic navigation is the first step, or the last step to robotics. The next thing which is coming is bioprinting, printing of cells with bone material. And thank you, Ray, for this gorgeous educational meeting. Together with DDS, we are awaiting you with Ray in October in Casablanca. And thank you for your attention.